all of our graduating residents must do a grand rounds. So they pick a topic of their interest and put it together, and that's part of their requirements for graduation. So Kunal, he picked a really interesting one, pediatric sepsis and biomarkers. So I'll turn it over to
Sure. Thank you, Dr. Buchini. Good morning, all. So we'll get started. Starting with disclosure, I have no financial relationship with any commercial interest related to the content of this activity. The objectives of this talk will be defining pediatric sepsis, management of pediatric sepsis, including goal-directed therapy as per the clinical parameters guidelines, and understanding the biomarkers related to pediatric sepsis. It's a very diverse topic, but I try to tailor it to keep it like clinically relevant. That way it can affect our clinical practice, not just in the ICU setting, but even periphery in a small community hospital or in the clinic, and just trying to go through the guidelines associated with the sepsis. So why this topic? Why talk about pediatric sepsis? Around 75,000 children in the United States are hospitalized for severe sepsis each year, with an annual incidence of about a case per 1,000 population. And occurrence of pediatric sepsis has been increasing steadily since mid-1990s, and now accounts for around 7% of patients treated in the pediatric ICU in the States. It is estimated that over 1/3 of these children who die in the PICU within the United States have severe sepsis. So as you can clearly say, it's a pretty high mortality associated condition. And obviously it remains a highly prevalent public health problem in critically ill children and is associated with substantial morbidity and mortality. There was a study done by Han et al. That showed that early use of practice consistent with the 2002 clinical practice guidelines, which we will briefly talk about in the coming slides. So based on those guidelines that were followed in the community hospital, it was associated with improved outcomes in the newborns and children. Mortality rate was down to 8% compared to 38%. So as you can see, like we'll talk more about it, but just based on simple measures that you can do, you can make a big impact in a condition like this. And just to give you a brief layout about the prevalence and the morbidity mortality associated with this condition, there's this study that came in 2015. It's about the global epidemiology of pediatric severe sepsis. It's the largest study done so far. It's focused on the prevalence, outcomes, and the therapeutic therapies associated with pediatric sepsis. So as I mentioned, there was a very limited data so far regarding the international burden of severe sepsis in critically ill children. And the objective of this study was to characterize the global prevalence, therapies, and outcomes of severe sepsis in pediatric intensive care units to better understand and conduct future interventional trials. So it was a point prevalence study that was conducted on 5 days between 2013 to 2014 at 128 different sites in 26 countries. So it's a pretty big study. And there were different endpoints. As you can see, they measured point prevalence, development of new or worsening of the existing multi-organ failure on presentation to the hospital, ventilator-free days, vasoactive-free days at 28 days, functional status, long-term morbidity and mortality were several outcomes that they were measuring in this study. And around close to 7,000 pediatric patients, less than 18, were screened in this study. And as you can see, like a median age range was around 3. Most frequent sites of infections were found to be respiratory, and followed by bloodstream as the second most common site. But the point I want you all to focus is, as you can see, the hospital mortality rate was 25%, and it did not differ by age or between developed or resource limited countries. And also 67% of patients had multi-organ dysfunction at sepsis recognition. And I'll talk more about what multi-organ dysfunction means in the coming slides. So a whooping 67% of patients that are admitted have multi-organ failure right at presentation. And with 30% subsequently developing new or having progressive worsening of that multi-organ dysfunction. And even if they were to survive all this, there were like 17% developed at least more moderate disability. So this shows how the impact is not only in the ICU setting in terms of mortality, but even a post-discharge, it carries a pretty high morbidity, and hence this topic. Moving on to the definition. So how do you define sepsis? The definition is basically based on the International Consensus Conference on Pediatric Sepsis. So there are two components to it.
It's on a video. Oh, he's cleaning.
So it's the SIRS criteria, systemic inflammatory response syndrome, and a proven or suspected infection. So it doesn't necessarily have to be a documented infection. Just a clinical suspicion of infection is good enough to fulfill the criteria. And again, it should be noted that the clinical concern for sepsis should not be limited to the predefined cutoffs that we'll just talk about. As an example, there was an observational study done of around 1,800 children younger than age 18 who were admitted to an ICU, and only two-thirds treated for severe sepsis or septic shock met consensus criteria at the time of clinical definition. So again, a high index of suspicion is very important right up front when you see the patient. So talking about that SIRS, which is one of the diagnostic criteria, as I mentioned, systemic inflammatory response syndrome. So you have to have at least 2 or more of these 4 criteria. One is the temperature, hyperthermic or hypothermic. Tachycardia, defined as more than 2 standard deviation above the normal for age, or children younger than 1 year of age. Bradycardia as a heart rate, bradycardia in the children less than 1 year of age for less than 10th percentile for age. Same thing with respiratory rate, more than 2 standard deviation above normal for age, or if they are on mechanical ventilator for any acute pulmonic process that's going on. And the fourth one is WBC count, which is elevated or depressed for age, or more than 10% immature neutrophils. So as you will realize, like the SIRS criteria meeting itself doesn't mean much, because if I ask one of you, or if I run up and down the stairs, take a couple of flights of stairs, I'll meet a couple of these SIRS criteria, including tachycardia and tachypnea. So along with this, you have to have a clinical concern or a proven infection to define it as sepsis. So we talked about sepsis. Now what do you mean by, so there is a continuum. So what do you mean by severe sepsis? So severe sepsis is anytime it is associated with a cardiovascular dysfunction, like a kid comes in hypotensive, or ARDS, the adult acute respiratory distress syndrome, or dysfunction in 2 or more organ system. That's defined as severe sepsis. And again, we'll talk about what exactly the dysfunction in the organ systems means. And the extreme is septic shock, when sepsis with cardiovascular dysfunction that persists in spite of aggressive fluid resuscitation within 1 hour of presentation to the hospital. So these are the criteria for multi-organ failure for sepsis in terms of cardiovascular, either hypotension, or if the kid is requiring vasopressors to maintain blood pressure, or 2 of the following. They may be having acidosis, their lactate may be high, they might have decreased wet diapers or decreased urine output, or a prolonged cap refill. Respiratory, PaCO2 more than 20, more than 50% of oxygen requirement to maintain sets, or the arterial PaO2 to FiO2 is less than 300. And this is one of the criteria for the ARDS severity. Neurological, any changes in mental status qualifies for an organ failure from that standpoint. GCS of less than 11 on presentation. In terms of hematologic presentation, platelet counts of less than 80,000, or a patient is in frank DIC. Renal, serum creatinine more than 2 times the upper limit of normal for age, or 2-fold increase compared to the baseline creatinine. And hepatic, bilirubin more than 4, or ALT more than 2 times the upper limit of normal for age. So anytime you see the sepsis definition along with at least 2 systems that are down, it's a severe sepsis. And if that patient is presenting with hypotension, you are dealing with septic shock. Some of the risk factors, serious injuries like burns, trauma, penetrating wound, indwelling catheters or devices, urinary tract infections or abnormalities, surgical incisions, chronic debilitating medical conditions, age less than 1 month, and most importantly, immunosuppression and lack of immunization. That's very important, especially some of these sickle cell patients that we see here, they are immunocompromised, or diabetic patients, got to be extremely cautious with this patient population. So I won't go into details about all the bacterial and viral causes and which are the most common and all, but I would like to bring forth the fact that when do you consider fungal infections? So anytime a patient having sustained neutropenia, or they have indwelling catheters, especially patients who are chronic TPN, or they are immunocompromised from any underlying medical condition, or recent use of broad spectrum antibiotic use. So just in the back of your mind, think about fungal infections. And especially in the patients that get admitted to the hospital, you are doing all appropriate things, and still 1 or 2 days down the line, you don't see the clinical recovery as you would have expected. You require more and more pressors. So think about fungal infection, fungemia. But an important thing to realize though is around 30 to 75% of children with sepsis have no infectious etiology identified. So it will be culture negative sepsis. And that's where the role of biomarkers come in, the clinical judgment come in, because at presentation, obviously you won't have the culture results, but 2 days, 3 days down the line, the blood cultures are negative, urine cultures are negative, CSF studies are clean, if relevant. So what do you do? Do you keep going, or do you cut short your therapy? How do you do? So that's where biomarkers come in with the clinical judgment and infectious disease. Okay, so I'm going to spend most time here talking about the management of pediatric sepsis. But what we need to realize before we actually go into the details of management is it's extremely important to recognize it early. As I mentioned, like no kid will come saying that, okay, I'm in septic shock or I'm having severe sepsis. You ought to be extremely cautious, especially look for any underlying condition, any immunocompromised state, or lethargic, or any decrease in mentation, decreased urine output, borderline blood pressure. Be extremely cautious. And I'll talk more about blood pressure, like how it's not a, it's not the only presenting, actually it's a very late presenting sign in a patient who is in severe sepsis. So that's not just the only parameter that should be focused on. And resuscitation should be done in a proactive, time-sensitive manner. Every minute counts, golden hour of resuscitation. We'll talk about that as well. And there was a study where they showed that every hour that went by without restoration of normal blood pressure for age and cap refill of less than 3 seconds, it was associated with a 2-fold increase in adjusted odds, mortality odds ratio. So you can tell like how significant it is for these patients to be managed, not just in the ICU, but even in clinic or outpatient settings. Another study done by Nainis et al. Reported an association between delay in inotropic resuscitation and close to 23-fold increased adjusted mortality odds ratio in meningococcal septic shock. And again, we'll talk more about inotropes in the subsequent slides. Talking about investigations, so when you encounter a kid presenting in sepsis, so obviously you do all baseline labs, CBC, CMP, you do pen cultures, depending upon the presentation may require CSF studies, throat swab, viral cultures, procalcitonin, CRP, lactate, blood gas, so and the relevant imaging as well. So where do this management guidelines come from? So it's from this clinical practice parameters for hemodynamic support of pediatric and neonatal septic shock, the 2007 update from the American College of Critical Care Medicine. So initially they came up with the guidelines for resuscitation and management of severe sepsis in 2002. And then in 2007 there was an update to this guidelines. So how different is this 2007 guidelines compared to 2002? And here they focused and emphasized the importance of first hour of fluid resuscitation and inotrope drug therapy directed to normalizing heart rate, blood pressure, and cap refill. And I can't emphasize enough about the importance of early fluid resuscitation, especially in the first 1 hour of us seeing the patients, and as well as using the inotropic drug therapy. And then subsequent once they get taken care of, initially stabilized, then the subsequent intensive care unit hemodynamic support, which is directed to maintaining ScVO2 of more than or at least 70 and cardiac index between 3.3 and 6. But the most important emphasis of this 2007 update was use of peripheral inotropes. So initially in 2002, it was a common understanding that, okay, we need to get central access, patient needs to go to the ICU, and then you start the inotropes. But 2007, there have been several studies, and they have shown that early introduction of inotropes also makes a huge impact. So you don't have to have a central access. In fact, you can get a peripheral IV or an IO, whatever is available, and start the peripheral inotropes within first 1 hour in a clinically relevant cases. So something that can be done right in the ER while patient is waiting for beds, or something that can be done in a community hospital setting while they are waiting for transfer to the outside facility, the higher level of care I meant. So blood pressure in children, how different is it? So unlike adults, in kids, hypotension is a late sign of severe sepsis. And when a kid is presenting with hypotension, already a lot of damage has already been done. It's a very late presentation. And why is that? Because if you can recall, cardiac output, it's stroke volume times heart rate. And heart rate in children is much higher compared to adults. So the fall of blood pressure in kids is a late sign. So it's an important sign, but at the same time, we need to be cognizant of the fact that a normotensive kid can still be having severe sepsis if all other clinical parameters are met. Okay, it's a crowded, it's a pretty busy slide, but this is exactly what step by step they recommend when you encounter a patient you are suspecting of having sepsis. So as you can see, the first thing is obviously ABC, airway, breathing, circulation. Make sure they are on supplemental oxygen. If there are any clinical clues for that, quickly establish an IV access. Now I want to focus on this initial resuscitation, and that's where our role comes in as a primary care providers. Push boluses, not just a single bolus, but boluses of 20 cc's per kg of isotonic saline or colloid up to and over 60 cc's per kg until perfusion improves or until patient you feel is developing signs of volume overload, like he's having a gallop rhythm, he's developing new crackles in the lung bases, he's developing hepatomegaly. Until then, keep giving the fluid boluses. And they even mentioned that, as you can see, like in first 5 minutes or so, if possible, try to get a second IV. And if after fluid boluses, and if you clinically think that your patient is not improving as you would like for them to, start thinking about getting an IV and a peripheral inotrope. So that conventional thing of, okay, getting a central access and starting inotropes only in an ICU setting, at least as per the standard guidelines, are not true. You can even start them out in the field or in the non-ICU setting. So talking about, and obviously you do all your pen cultures and you begin antibiotics. Again, you need to be aware that we cannot afford to lose time while they draw cultures. You need to start the antibiotics soon if cultures cannot be obtained in a timely manner. That should not be a reason for delaying the antibiotic use, because along with fluid resuscitation, the second most important thing that we need to focus on is source control. And antibiotic therapy is one of the important important fundamental behind source control. So you do fluid resuscitation, you give 20 cc's per kg, you reassess the patient, you give another bolus, you keep giving the boluses, and still patient is having shock, which is what we call fluid refractory shock. So that is when you now start worrying about getting a central access and making sure, if need be, to secure an airway. And unlike like how in medical, the adult side, they use etomidate and all, that's a complete no-no when you are attempting intubation in the pediatric patients, because they say that it causes a pretty significant decrease in the preload, and a patient who is already hypotensive or on the verge of becoming hypotensive, you drop that preload and you make their shock even worse. So the recommendation is to use either ketamine or atropine for that intubation purpose. But again, you need to be careful that when you are attempting that intubation, chances are that your shock can worsen. And then reverse the cold shock by using dopamine, or if it continues to be resistant, use epinephrine. And if you are dealing with warm shock, then use central norepinephrine. And let's just quickly talk about what I mean by cold and warm shock. So just briefly, I mean, you'll see tachycardia in either shock, but in cold shock, obviously it will be cool peripheries. In warm, it will be warm. Pulses will be difficult to palpate in cold shock, whereas it will be a bounding pulses in warm shock. So again, if we get a good pulses, doesn't mean that, okay, patient has a good perfusion and we are good and he's not like crashing, but yeah, that can very well be warm shock. And rest all, I mean, pretty much is the same in both. So coming back to our slide, so you try these pressors and still shock is not improving. What do you do? So it's called the catecholamine resistant shock. So now you start using hydrocortisone. So you go with IV fluids, you do source control, you do antibiotics, and you start inotropes, and still pressure is not improving. Then you need to start thinking, and in fact even going ahead with the hydrocortisone infusion. And as you can see, like this all has to be done, is recommended to be done in first 60 minutes of presentation to the hospital. And for hydrocortisone, you don't have to necessarily document adrenal insufficiency. In fact, there is no point of trying to procure a cortisol level and then based on the levels. On adult side, at least sometimes we do, when patient is on couple of different pressors and is still not getting better, we do baseline cortisol. If it is less than 20, we try to add hydrocortisone. But there is no such literature in hydrocortisone, I mean on the pediatric side. But in a patient who is on chronic steroids, who has known adrenal insufficiency, who is on couple of different pressors and still is not improving, then you got to go ahead and give hydrocortisone. The doses range somewhere between 2 mg per kg per day as high as 50 mg per kg per day, depending upon how they respond to the shock. And then obviously once this is done, once your patient is stabilized, you send them to the ICU and do the close monitoring for SCVO2 and MAP. And this is pretty much the same, and it's more so in the ICU setting, like what pressor to use when, what's your second alternative pressor that you can add if patient is not improving. And after all this, if your patient still not improving, then think about something like pericardial effusion, think about pneumothorax, think about intra-abdominal hypertension in a clinically relevant case. A kid comes in with a distended belly, you give fluids, you start pressors, is still not getting better, is still appearing in distress. Think about intra-abdominal hypertension from ischemia or any perforation or things like that. How do you quickly assess for intra-abdominal hypertension? You can get a bladder pressure, and it will give you, it's like a surrogate marker for intra-abdominal hypertension. So something that you can quickly do and get an answer to. And if it's still not getting better, then obviously the last resort is ECMO. So I just want you to realize the importance, like in first 60 minutes, they are recommending use of fluids, antibiotics, pressors before even patient gets to the ICU. And I know it can be, I mean, having said that, clinically it can be challenging to be achieved in first 1 hour. So as I just mentioned, the therapeutic endpoints for all this will be normalizing heart rate, cap refill, and normalizing the pulse, warm extremities, blood pressure normalization, making sure urine output is at least 1 ml per kilogram per hour, normal mentation, and a CVP of at least 8. So some of the key points. Fluid losses and persistent hypovolemia secondary to diffuse capillary leak can continue for several days in patients with sepsis. So after initial resuscitation, the job is not done. They can still continue to third space, and you need to stay on top and try to replace it while you are taking care of these patients. Rapid fluid boluses of 20 ml per kilogram can be administered by push or rapid infusion device like a pressure bag while observing for signs of volume overload, which I just talked about. And again, in fact, the recommendations are to push the IV fluid within a matter of 5 to 10 minutes and keep giving those boluses until those therapeutic endpoints that we just talked about, like normalizing heart rate, normalizing blood pressure are met. You need to keep giving the IV fluid boluses, and you need to check for signs of volume overload. And as you can see, the repeated fluid boluses can be administered up to as high as 200 milligram per kilogram in the first hour. And I am sure most of you all must be thinking like, wow, that's way too much fluid and I'll drown my kid. But I'll talk more about it, like how that actually doesn't correlate with pulmonary edema or developing ARDS. And as you can see, children commonly require 40 to 60 ml per kilogram in the first hour, and foods can be pushed with the goal of attaining normal perfusion and blood pressure. Large volumes of fluid for acute stabilization in children have not been shown to increase the incidence of ARDS or cerebral edema, as I just talked. And for optimal oxygen delivery, it's important to maintain a hemoglobin of at least 10 in this patient population. Okay, the second guidelines. In adult population, we go by the surviving sepsis guidelines. It's an international guidelines for management of severe sepsis and septic shock. Initially came out in 2008 and then a subsequent revision in 2012. It's a consensus committee of 68 experts representing 30 international organizations, and the recommendations are intended to provide guidance for the clinician caring for patient with severe sepsis or septic shock. And the important thing to realize is these recommendations for the severe sepsis patient are not just for the ICU setting, it's even in the non-ICU setting. And again, these recommendations are just intended to be the best practice, but it's not a standard of care, because some of the developing countries may not have resources to follow these guidelines in a timely manner. So something called the survival sepsis bundles. So basically what it means is what you got to accomplish within a certain time frame of patient's presentation, like what needs to be achieved in first 3 hours, what needs to be achieved within the first 6 hours. Again, it shows how important the time is after patient's presentation to the hospital. So in first 3 hours, make sure you measure the lactate level, obtain cultures prior to administration of antibiotics, begin broad spectrum antibiotics, and administer the fluid boluses that we just talked about. And within first 6 hours, start vasopressors for hypotension that is not responding to appropriate fluid resuscitation. And the goal MAP is at least 65. And in the event of persistent arterial hypotension, or if the lactate continues to stay high, measure CVP, SCVO2, that will help you with the fluid resuscitation. And remeasure the lactate if the initial lactate was elevated. So the pediatric considerations in this sepsis guidelines, like they had a separate section just focusing on the pediatric patients, and the recommendations are only for the term newborns and children in the developed countries with full access to mechanical ventilation. So talking about initial resuscitation, so the kids typically have low functional residual capacity, so they may require early intubation compared to adult population. And as I just talked about, during intubation and mechanical ventilation, it causes increased intrathoracic pressure, and that can reduce the venous return and lead to worsening of the shock. Because attainment of central access is more difficult in children than in adults, reliance on peripheral access can be substituted until and unless central access is available, including delivery of the peripheral inotropes, which I just mentioned based on the 2007 recommendations. And evaluate for and reverse underlying cause like pneumothorax, pericardial tamponade, or endocrine emergencies like hypoadrenalism, hypothyroidism in patients with refractory shock. And in select patient, always be aware about any intra-abdominal hypertension that might be going on. So the therapeutic endpoints of resuscitation of septic shock patients, as we mentioned, capillary refill less than 2 seconds, normalizing blood pressure, normalizing the pulse, warm extremities, making sure you have a good urine output of at least 1 ml per kilogram per hour, and normal mental status. And subsequently in the ICU setting, maintaining an SCVO2 of 70 or more and a cardiac index between 3.3 and 6. So it's in lines with the 2007 guidelines that we just talked about for the pediatric patients. Antibiotics and source control. Again, the emphasis is on empirical antibiotics should be administered within first hour of identification of severe sepsis. and obtaining culture should not delay the initiation of antibiotics. But something very clinically relevant in pediatric patient compared to the adults is the fact that some of these kids can present with toxic shock syndrome, and the only presentation that they may have is a vague rash. So the recommendation is to use clindamycin along with the empiric broad spectrum antibiotics that you are starting for that proposed toxic shock syndrome presentation, and you can always later de-escalate if you rule that out. So just showing the rash that may be associated with the toxic shock. And again, it's a very serious condition, secondary to invasive group A streptococcal infection, and it can occur at any age but is especially common in young children. Because of the lack of specific signs and symptoms and its very rapid progression to shock and organ dysfunction, pediatricians and ER physicians must be aware of this possibility and immediately initiate aggressive treatment whenever you suspect it. So the rationale behind it is because children are more prone to toxic shock than adults because of their lack of circulating antibodies to these toxins. And children with severe sepsis and erythroderma with suspected toxic shock should be treated with clindamycin to reduce the toxin production. The role of IVIG is unclear, so it's a clinical judgment. But again, recommendation for early and aggressive infection source control. Fluid resuscitation, again, in the same lines, initial resuscitation with crystalloids or albumin with repeated boluses over a period of 5 to 10 minutes. And as you can see, fluid it's recommended for not just hypotensive but also normotensive children, and you may require 40 to 60 or even higher of fluid resuscitation and titrating for these endpoints that we talked about. Steroids, again, I mentioned to start empirically hydrocortisone in some of these patients. Why? Because death from absolute adrenal insufficiency and septic shock can occur within first 8 hours of presentation. So that's how important it is to initiate hydrocortisone right up front if patient is not responding to pressors or to the fluid resuscitation. Okay, so having talked about all this, we come to a point like, okay, is it even clinically possible? Can we implement this in a hospital setting, and can we see a difference? And yes, you can. There is this good study that was done in Houston, the implementation of this goal-directed therapy that we just talked about in children with suspected sepsis in the emergency department. That was published in 2011. So it was conducted in the Texas Children's Hospital, and there were some resuscitation timeliness was measured by documentation of time from their triage to the initiation of flood first and the subsequent boluses of fluid, the volume and the duration of boluses that were given, the timing of vasoactive agents that were given, the antibiotic use and their timing. So basically all we just talked about in the practice guidelines, those were their objectives. They were looking at exactly how long it took for them to administer the fluids and the antibiotics and cultures and all that. And I'll just skip this. So basically they had, if a patient who appeared high risk or ill, there was a triage nurse who was empowered to call the charge nurse and activate the protocol. So they did not even have to wait for a physician to respond. If they thought it was required, they started the protocol, and and after that a physician was notified, and at any point a physician could terminate or initiate this protocol, or anyone could be taken off of the protocol if he had good improvement. This is just their triage algorithm that they used for the study. And again, a very, very busy slide, but basically they had the different parameters that they were monitoring and the timeliness of implementation of each of these parameters. So on this slide, you can see huge difference based on this implementation of protocol in terms of administration of the first fluid bolus in this graph A. This B represents the difference in the third fluid bolus time. Like you can see how those patients that were enrolled in the protocol, the time to initiate the first fluid bolus versus those were not in the protocol, third fluid bolus here. And the last one shows the antibiotic administration in the patients that were enrolled in the protocol. So a significant difference by implementing this protocol. Results. So the triage to first bolus, the time was 22 minutes compared to 72 minutes in when protocol was not used. Third fluid bolus, 61 minutes compared to 280 minutes. Time to first antibiotic use, 38 minutes compared to 143 minutes. And a difference in mortality as well between the two groups. So yeah, I mean a significant statistically difference between the protocol group versus not that was not in the protocol. So what I'm trying to say is, yes, it is feasible if done in a appropriate manner. If you have a set parameters, you can something that we can implement and make a big difference. And again, why does aggressive and early fluid resuscitation matter? And as a community physician, can we make a difference outside of the ICU setting? To answer this, I came across this study where they showed early reversal of pediatric and neonatal septic shock by community physicians associated with improved outcomes back in 2003. The objective of this study was to determine whether early septic shock reversal and use of resuscitation practice consistent with the ACCM and the PALS guidelines that we just talked about by community physicians is associated with improved outcomes or not. Basically, a 9-year retrospective study was done around 91 children and infants who presented to the local community hospital with septic shock and required subsequent transfer to the higher hospital were recruited in the study. And again, if you see the results, the survival of the patients in this group that the shock was reversed by proactive physicians giving good fluid resuscitation was close to 96%. And in the group that had persistent shock, as you can see, the survival rate was like close to 60%. A significant difference between the two groups, just with a simple thing like fluid resuscitation. And again, resuscitations that were consistent with the 2007 guidelines, mortality, the survival close to 95%, and here barely close to 60%, and both are statistically significant differences. So successful shock reversal by the community physicians was associated with greater than 9-fold increased odds of survival. Resuscitation consistent with the ACCM and PALS guidelines was associated with more than 6-fold increased odds of survival. And each hour of persistent shock that passed without appropriate resuscitation was associated with more than 2-fold increased odds of mortality. And each hour of delay in institution of resuscitation consistent with the ACCM PALS guideline was associated with a 50% increased odds of mortality. And again, as you can it's a busy slide, but just to focus here, only 45% of the patients in this study received appropriate fluid therapy in a community hospital in a non-ICU setting. And only 30% of those kids received the resuscitations that were consistent with the guidelines. So conclusions, extremely important, immediate and aggressive fluid resuscitation of these children should be the community physician's first priority rather than delaying resuscitation while waiting transfer to the referral center. And effective intravascular volume is even more dramatically reduced in septic patients by fluid leaking across the capillary membranes as well as by venous and arteriolar pooling. The cardiac contractility is impaired in sepsis. So if adequate preload is not provided, then the heart dilates to compensate for diminished contractility and stroke volume is maintained despite a decreased ejection fraction. And the importance, can't emphasize enough, the importance of fluid resuscitation is further emphasized by diminished cardiac and vascular tissue responsiveness to inotropic and the vasopressors that you are using subsequently. And there has been several animal models of severe sepsis that required up to 60 ml per kilogram of fluids in the first hour of resuscitation to maintain, to obtain maximal cardiac output, O2 consumption, and hemodynamic stability. Okay, so the question then comes like, okay, what about the risk of developing ARDS and cardiogenic pulmonary edema by giving such aggressive fluid resuscitation? So the answer to this article that was published in JAMA in 1991, it dates back several years, and a very important study where they showed the role of early fluid resuscitation in pediatric septic shock patients. So basically, they just try to examine the association of volume of fluid administered within first and the 6th hour of presentation to the hospital with the survival of the patients in these groups and the occurrence of ARDS, cardiogenic pulmonary edema, persistent hypovolemia, and during this first 6 hours in these 2 different groups. So what they did is they divided patients in 3 groups. First one was that received less than 20 cc's per kg of fluid resuscitation, second group between 20 and 40, and the third group received more than 40 ml per kilogram of fluid resuscitation within that first hour of presentation. Around 34 patients were identified, and let's look at the results. So as you can tell, look at this group 1 and group 3. Mortality, the non-survivors were higher in these 2 groups, and look at group 3 that received more than 40 cc's per kg of fluid resuscitation, and it was a statistically significant difference compared to group 3 where they received more than 40 of fluid resuscitation compared to the prior 2 groups. Again, in these 3 groups, persistent hypovolemia, 0 patients at 6 hours, while around 6 and 2 patients still had hypovolemia at the 6 hours of monitoring. And deaths in these patients with persistent hypovolemia. All 6 patients that had hypovolemia at 6 hours died. All 2 patients in this group 2 that had hypovolemia at 6 hours, they died. And no mortality in the group that received more than 40 ml per kilogram of fluid. Now talking about the risk of developing ARDS and cardiogenic pulmonary edema. As you can look at the results, there is no statistical significant difference. So irrespective of what fluid you give, it doesn't change the risk of developing ARDS or pulmonary edema. Just so to answer the question, aggressive fluid resuscitation does not increase your odds of developing ARDS or pulmonary edema. But at the same time, you need to be clinically be careful and examine your patients frequently and make sure they are not developing any signs of volume overload. Okay, so the conclusions, this study represents the first evaluation of the volume of fluids required in the resuscitation of patients with pediatric sepsis shock. Rapid fluid resuscitation using fluid volumes in excess of 40 in the first hours was associated with an improved outcome in this group of children with septic shock. And rapid fluid resuscitation was not associated with an increase in the risk of cardiogenic pulmonary edema or ARDS, and was associated with the decreased incidence of persistent hypovolemia at 6 hours following ED presentation. And based on the study findings, some kids may require as high as 120 ml per kilogram in the first 6 hours if perfusion remains decreased. Okay, so now shifting to biomarkers. Just the definition in NIH has defined it as a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic response to a therapeutic intervention. And WHO has defined this as any substance, structure, or process that can be measured in the body or its products and influence or predict the incidence of outcome or disease. So we all are familiar with procalcitonin, and that's what we check at baseline in suspected sepsis patient. We serially monitor that, but it comes with its own limitations. It can be increased in several other conditions like trauma, extensive burns, pancreatitis, transplant, major surgeries, etc. And its positive and negative predictive values are not sufficient to rule in or rule out sepsis in a standalone test. And also based on my experience so far during my training, for most part, it does follow a clinical course, but there have been few patients where it makes no sense the way procalcitonin trends. And I don't blame procalcitonin because sepsis, it's such a complex process. There are so many heterogenic processes going on, so many cytokines involved. So we can't expect one biomarker to truly reflect all this. So I was reading about some novel biomarkers and came across presepsin. Basically, it is a soluble CD14 that is expressed in macrophages, monocytes, and granulocytes, as well as on their cell surfaces. So there have been lots of studies that I found about presepsin, again a good biomarker, and its comparison to procalcitonin and how presepsin was superior to procalcitonin. So I came across this study that showed usefulness of pre-sepsin in the diagnosis of sepsis in a multi-center prospective study published in 2012. So just quickly going to the results, as you can see, the receiver operating characteristic curves for pre-sepsin, procalcitonin and IL-6 was compared in a sepsis patient, and as you can tell from this, pre-sepsin had a better ROC compared to procalcitonin. And the results, the usefulness of pre-sepsin for diagnosis of bacterial infection was comparable to procalcitonin in this study, but the clinical specificity of pre-sepsin was much higher than that of procalcitonin. Pre-sepsin is a highly specific marker for the diagnosis of bacterial infection because of its mechanism of production by bacterial phagocytosis, and pre-sepsin was secreted from the granulocytes by the infectious stimuli. However, the production mechanism of procalcitonin remains unknown, so that was the rationale why they thought pre-sepsin was superior to procalcitonin. Lots of pre's here. And also, based on this results chart, there was no significant difference in the levels of pre-sepsin between blood culture positive and blood culture negative patients with the sepsis. So pre-sepsin levels may allow a decision to continue antibiotic treatment in the case of culture negative sepsis patients, is what this study claims. Another study, a bigger study, this study enrolled around 859 patients. So they also tested for the diagnostic value and prognostic evaluation of pre-sepsin for sepsis in the ER setting. It was based in Beijing, China, and the study was done from December 2011 to October 2012. And patients were risk stratified into SIRS criteria only, sepsis, severe sepsis, septic shock, and they again tried to measure pre-sepsin, procalcitonin levels and tried to see if there was a difference. So as you can obviously, as you can see, like as the severity of the sepsis increases, the pre-sepsin level goes up, and same thing with the procalcitonin as well, is what they found. Again, ROC, pre-sepsin was found to be superior to procalcitonin, and this was a statistically significant difference. Looking at this graph, pre-sepsin when compared with some clinical parameters for checking the severity like the Apache score or the MED score, so their combination was superior to procalcitonin in this study. And based on the results on this, basically what it boils down is they are trying to say that procalcitonin was not found to be an independent predictor of severe sepsis and a 28-day mortality. So some of the key notes of this study was that this study indicated that pre-sepsin was a more valuable biomarker than procalcitonin in the early diagnosis of sepsis, and pre-sepsin in combination with some of these scores like MED score, Apache score, significantly increased the prognostic accuracy in septic patients. And pre-sepsin appears to be a promising biomarker for early diagnosis, risk stratification, and evaluation of prognosis in septic patients in the ED. Pre-sepsin was superior to procalcitonin for diagnosing, predicting severe sepsis and septic shock, as well as 28-day mortality in the septic patients. And when, again, we talked about that graph, when it was combined with this clinical scores, it enhanced the predictive accuracy of severe sepsis prediction and septic shock as well as 28-day mortality. So convincing results, but then I came across this systemic review and meta-analysis. So basically what it was like close to 9 studies with 10 trials, and around 2,200 patients were included in this study. And what they showed was that when focused on studies aimed at discriminating sepsis from non-infectious SIRS, the accuracy of pre-sepsin was the same as that of procalcitonin with respect to the AUC. Pre-sepsin did not show any advantage in diagnostic performance of sepsis compared to procalcitonin, and it cannot be recommended as a single definitive test for sepsis diagnosis. Pre-sepsin, however, showed some superiority in the management of patients because pre-sepsin can signal a much earlier and faster increase in sepsis patients and perform a unique capacity of distinguishing the severity of sepsis. So the point I was trying to get at is there have been several studies, I quoted 2 of them that show pre-sepsin is superior, is great, but if you look at the meta-analysis, they didn't see a difference. So then what about the future? What biomarkers do we expect, or what do we think is going to help us clinically. So then I came across this pediatric sepsis biomarker risk model. So Dr. Wong, she has multiple publications specifically targeting the pediatric sepsis patients. So what her lab has been doing is they have done an extensive study on the patients that get admitted to the ICU and studied their genomes and tried to figure out like what all biomarkers get elevated. And there have been like 7 to 8 different biomarkers that they have consistently tested and found that they play a crucial role in the pathogenesis of sepsis. So then they tried to test those biomarkers in the patients clinically and see if they could predict the mortality of the patients based on that biomarker panel. So just a background. So as I mentioned, they came up with this risk model to estimate mortality probability in children with septic shock, and they called it Persevere, so pediatric sepsis biomarker risk model. So it's like a panel of 7 to 8 different biomarkers. And they wanted to test the accuracy of this biomarker panel in the sepsis patients. Methods, so the study subjects were recruited from multiple PICUs across United States, and biomarkers were measured in 182 pediatrics patients with septic shock using their serum samples that were obtained in first 24 hours of presentation. And patients were enrolled over a 2 years period between 2011 and 2013. And then again they had like this different therapeutic, the outcomes, like they measured the 28-day mortality, vasopressor free days, ventilator free days, long-term morbidity is what they measured. So basically this result slide is what they came up with, what they call its terminal node. So what, as you can see, like this all are terminal nodes, and the patients were like based on the serum values, they were assigned to one of these groups depending upon what the results came up with. And each of these terminal node provides the total number of patients in the node, the cutoff value for the biomarkers, or age, the number of survivors and deaths with the respective rates, as well as the respective mortality in each group. So what they found out was that in some of these terminal nodes, like if 2, 4, and 7, they have serially numbered it like 2, 4, 7 here. They are low risk terminal nodes based on the processing of the samples from their patients, and their mortality probability was between 0 to 0.025. Then groups 1, 3, and 5 were intermediate risk, and they had a mortality probability of 0.182 to 0.267. And the last group, the terminal nodes 8 and 6, was the high risk group, and their mortality probability was somewhere between 0.472 to 0.62. So they were blinded and they had all these results, and they wanted to see whether their mortality prediction in one of these 3 groups, low risk, intermediate risk, high risk, actually like related to the actual mortality of the patients while they were admitted to the ICU. And they were among the subjects that were predicted based on this biomarker risk panel. Those that were in the intermediate or high risk category had a mortality of 33.9%, whereas those patients that they had predicted had a low risk mortality had actually just 3.3% mortality. So very, very convincing results. Just the key points. So this pediatric sepsis biomarker risk model was developed to provide a simple, accurate, and objective method for risk stratification of these patients, and to better understand the heterogeneity that underlies the pathophysiology of sepsis, and to avoid one-size-fits-all therapeutic strategy. And then just a last study that I have, it's again done by the same department, and what they tried to show in this study is again the patients were that were admitted to the ICU, they were classified in these different nodes, and here they tried to explain the pathophysiology. So again, patients based on the biomarker values, like you can see CCL3, HSPA1, ILB, GZMB, MMP8, matrix metalloprotein. So these are all different biomarkers involved in the sepsis pathophysiology. So again, they grouped the patients depending upon their values in each of these terminal nodes and came up with same 3 categories: low risk, intermediate risk, and high risk. And what they suggested was that the intermediate risk, like in group 3 and 6, it suggests hyperinflammation is incomplete in some patients reflected in the fact that they have intermediate probability, mortality probability. So what they try to show is, if you can look, I know it's difficult to interpret, but in the intermediate group, they showed that some of the biomarkers were up and some of the biomarkers were down. So hence they were in the intermediate group. So what they are trying to say is, there was only the hyperinflammation state was only partially achieved, and hence they had intermediate probability. In the high risk group, they showed that all these biomarkers that they tested were up, and no wonder, like the hyperinflammation was at its peak, and hence that group had a higher mortality. Whereas in the low risk group, they showed that most of the biomarkers were suppressed, and hence was associated with a lower mortality prediction. And also, I was looking in their study, and they said that in sepsis, it's like a continuum. We just think about hyperinflammation. We think that everything is inflamed, cytokines are released, and that's what causes sepsis. But they said that it's not just hyperinflammation, it's also immunosuppression that works. And in fact, they even mentioned that in any given patient, it's a combination of both. You will see hyperinflammation as well as immunosuppression going on together. So it's that dynamic and that complex. And hence they came up with such biomarker risk panel that had multiple biomarkers which could possibly answer our questions and help us with the prognostic evaluation. Now the question is then, what about the 2007 and the 2012 guidelines? Will they be able to provide such results in a timely manner, like especially when we are talking of minutes? So they are claiming that they do have this platform where they can generate this biomarker data within 20 minutes of patients hitting the ER door, and you have the results right in the ER setting itself. So just to summarize, biomarker-based stratification tools can be used to decide which patients are at highest risk for death or outcomes. Biomarkers provides a snapshot of sepsis biology based on selected biomarkers, and future sepsis interventional clinical trials could include biomarker-based data to select patients that are most likely to benefit from a given experimental intervention. And using biomarkers to profile sepsis biology for individual patients may ultimately guide personalized therapy and avoid one-size-fits-all approach. And those are some of my references, and that's it. Thank you.
Very nicely done. I know we're running out of time, but are there any quick questions, comments from the intensivists in the back?
No, very well done. We actually contributed some of those samples to Dr. Long. So here we've actually worked with him before, and he's onto it. You know, he's on the right track. This is not going to be that we can modify our therapy based on the genomic profile of the patient we see. And we're probably, you know, a year or two away from getting that as a standard therapy. So it's pretty quick, and it's basically based on genomic expression, and he's validated with proteomics. And so we're going to have all these, you know, ProCal, you know, CD14, whatever the next big one is, but the profile is probably going to be the most important. So, but I like what you said, don't blame procalcitonin. We put a lot of pressure on that test. Right? So it's still malinterpreting, and you have to take it in context and use it, because procalcitonin can be a prognosticator or a diagnostic differentiator, and it's much more valuable as a prognosticator. So if it's high and you see a fall, that's probably valuable. But if being low and someone's sick, it doesn't mean anything. So don't put too much pressure on any test.
Well, I think it's interesting that for many years we've been trying to find the one test that would help you clinically rule in or rule out a seriously ill patient, and no, we haven't found it. And now, looking at genomics, we're looking at the whole response to an episode of infection that might lead to a disordered response or a more severe response, and now potentially personalizing therapy. So it's really an interesting transition that's coming about.
How long does it take to get these results back?
So in study they mentioned that they can actually provide results within 20 minutes.
In this hospital?
They actually get ProCal pretty quick, and took us years to get it. You know, and they actually have a point of care procalcitonin test now. That's 6 drops of serum, and you get it in 30 seconds. So it's designed for a clinic use, but I don't know really where it's going to fit. But for this genomic proteomics profile, it's going to be a monoclonal antibody. So, it's just drops of serum and wait for it. It's red, blue, whatever. It's going to be a pretty quick turnaround test.
But I think the important thing to remember is the early part of your talk, which is being on the alert for subtle things that tell you that you've got a sick patient that needs resuscitation. And I think that's the key to managing sepsis, is identifying it early and then doing what's needed and being prepared to do the things that you indicated were required within that golden hour. So it's important. All right. Thank you very much.
Thank you.